Hyponatremia, low sodium. Scene 1. Paramedics arrive. The call comes from a daughter who found her father acting not himself. When the crew arrives, they find a 72-year-old male slumped on the couch. His clothes are damp with sweat, and his skin is pale, almost gray. He's confused, repeating the same words over and over. His hands tremble when he tries to lift his water bottle. The daughter explains he's had 3 days of nausea, vomiting, and diarrhea. He's been drinking a lot of plain water to stay hydrated, but has barely eaten. Normally, he takes a thiazide diuretic for high blood pressure and an SSRI for depression. Recently, he's seemed weaker, stumbling when walking, with swollen ankles. Visual signs noted by paramedics: dry lips and tongue despite water intake, muscle twitching, and occasional spasms in his legs. Altered mental status: slow to respond, disoriented. Mild ankle edema. Scene 2, en route. His level of consciousness declines further. His eyes roll back, and he has a short tonic-clonic seizure. Paramedics secure his airway, give oxygen, and prepare IV access. They note low blood pressure, 90/60, tachycardia, and clammy skin. Scene 3. Handover to emergency team. Elderly male with GI losses, excessive water intake, and medications that predispose to hyponatremia. Found with confusion, tremors, and seizure en route. BP 90/60, HR 110. Labs confirm Na plus 118 millimoles per liter. Mechanism explained. Teaching moment. The ED physician explains. Sodium is the key extracellular ion that regulates fluid balance. When sodium drops, water moves into cells to equalize osmotic pressure. In the brain, this swelling causes cerebral edema, confusion, tremors, seizures. His thiazide diuretic increased sodium loss, vomiting/diarrhea worsened it, and excessive water diluted his remaining sodium further. Scene 4. Treatment plan. Start 3% hypertonic saline, slowly to raise sodium no faster than 8 to 10 millimoles per liter in 24 hours to avoid osmotic demyelination. Frequent neurochecks and repeat electrolytes every 2 to 4 hours. Seizure precautions. Review and hold offending meds. Thiazide SSRI. Replace ongoing GI losses with balanced IV fluids. The daughter is relieved to hear. We're correcting things gradually. The seizures are from low sodium, not a permanent condition. Careful correction will help bring him back. Hypernatremia, high sodium. Scene 1. Paramedics arrive. The call comes from a neighbor. An 84-year-old woman has been increasingly confused, barely drinking, and now collapsed in her kitchen. The paramedics find her lying on the floor, frail and agitated. Her mouth is so dry, her tongue sticks to her palate. Her eyes are sunken, skin is tented from loss of elasticity. She mutters incoherently, then becomes combative when moved. The neighbor explains. She lives alone, has dementia, and forgets to drink. Her meds include a loop diuretic and antihypertensives. It's been a heat wave this week. Visual symptoms observed: dry mucous membranes and cracked lips, poor skin turgor, sunken eyes, restlessness and irritability, alternating with lethargy. Vital signs: HR 120, tachycardic, BP 88/55, RR 28, tachypneic. Scene 2, en route. She becomes drowsy, then has a brief episode of jerking movements. Paramedics start IV access and begin slow isotonic saline. They notify ED of possible severe dehydration with electrolyte imbalance. Scene 3. Handover to emergency team. Elderly female, dehydrated, dementia history, likely not drinking in this heat wave. Altered LOC, tachycardic, hypotensive, found with dry mouth, poor turgor. Had seizure-like activity en route. Fluid started. Lab work shows Na plus 162 millimoles per liter, very high. Mechanism explained. Clinician teaching moment. The attending physician explains to the residents. Sodium is the primary extracellular solute. In hypernatremia, there is water deficit relative to sodium. This causes water to move out of cells into the extracellular space. Neurons shrink as water leaves. Confusion, irritability, seizures, coma. In her case, dementia, inadequate thirst drive, diuretic use, more water loss, heat wave, insensible fluid losses, severe hypernatremia. Scene 4. Treatment plan. Begin careful correction with hypotonic fluids, e.g., D5W or 0.45% saline, but slowly. Goal: lower serum sodium by no more than 10 to 12 millimoles per liter in 24 hours. Monitor neurostatus and serial sodium checks. Address underlying cause. Ensure long-term hydration support. Adjust medications. The ED nurse reassures the neighbor. Her sodium is dangerously high, but we're lowering it slowly. If corrected too fast, her brain could swell. We'll stabilize her carefully. Hypokalemia, low potassium. Scene 1. Paramedics arrive. A 65-year-old man is found slumped beside his bed. His wife reports he's been too weak to stand and has had persistent vomiting for several days from a stomach flu. Paramedics note he is alert but very weak, with shallow breathing. His arms and legs twitch intermittently. Visual/physical signs. Flaccid muscle weakness, especially in the legs. Fine muscle tremors in the hands. Shallow, irregular respirations. Skin pale, diaphoretic. Vital signs: HR 128, irregular. B, P95/60. His wife explains he takes a loop diuretic for heart failure and hasn't been eating well due to nausea. Scene 2. En route. On the monitor, his heart rate suddenly becomes irregular, showing premature ventricular contractions, PVCS. Paramedics apply oxygen, start IV, and report possible electrolyte abnormality with cardiac involvement. Scene 3. Handover to emergency team. Male, 65, vomiting for several days, loop diuretic use, generalized weakness, irregular tachycardia en route, PVCS noted. Currently stable but weak, with muscle tremors. Labs confirm K plus 2.4 millimoles per liter, severely low. Mechanism explained. Clinician teaching moment. The ED physician reviews with the team. Potassium is vital for resting membrane potential in muscle and nerve cells. Low potassium makes cells hyperpolarized, harder to depolarize. This leads to muscle weakness, decreased reflexes, shallow breathing, and ileus. In the heart, low potassium increases risk of arrhythmias, PVCS, tachyarrhythmias, even ventricular fibrillation. His diuretic and vomiting both increased potassium loss. Scene 4. Treatment plan. Begin 4 potassium chloride infusion, never IV push, to avoid cardiac arrest. Continuous cardiac monitoring, supplemental oral potassium once tolerated. Correct underlying cause, adjust diuretic regimen, antiemetics for vomiting. Monitor magnesium since low Mg2+ can worsen hypokalemia and make replacement ineffective. The ED nurse explains to his wife, his weakness and irregular heartbeat are from very low potassium. We'll replace it carefully through his IV. It has to be slow, but you should see him start to regain strength. Hyperkalemia, high potassium. Scene 1. Paramedics arrive. The call comes from a dialysis clinic. A 58-year-old man with chronic kidney disease collapsed in the waiting room before his session. Staff say he's missed 2 dialysis appointments this week. When paramedics arrive, he is drowsy but responsive. His skin is warm and clammy. He complains of weakness and tingling in his hands. His breathing is rapid and shallow. Visual/physical signs: muscle weakness in both arms and legs, tingling around lips and fingertips, irregular weak pulse. Vital signs: HR 42, bradycardic, BP 85/55, SPO 294%. Scene 2. En route. On the cardiac monitor, the paramedics see peaked T waves, then widening of QRS complexes, a dangerous rhythm pattern. They start high-flow oxygen, place pads for possible pacing, defibrillation, and call ahead to the ED, possible severe hyperkalemia with bradyarrhythmia. Scene 3. Handover to emergency team. Male, 58, ESRD, missed dialysis, collapsed with weakness and paresthesias. Bradycardic with peaked T waves on monitor. Blood pressure 85/55, IV established, O2 running. Labs confirm K plus 7.2 millimoles per liter, dangerously high. Mechanism explained, clinician teaching moment. The ED physician explains. Potassium regulates the resting membrane potential of cells. High potassium depolarizes cells, making it easier for them to fire initially, but sustained depolarization inactivates sodium channels. Result: muscle weakness, paresthesias, and slowed conduction in the heart. Cardiac changes progress from peaked T waves to widened QRS to sine wave pattern to cardiac arrest. His kidneys cannot excrete potassium effectively, so it builds up. Scene 4. Treatment plan. Immediate cardiac stabilization. Intravenous calcium gluconate to stabilize cardiac membranes. Shift potassium into cells. Intravenous insulin with glucose and nebulized albuterol. Remove potassium from body. Emergent dialysis is definitive. Also consider potassium binders. Sodium zirconium cyclosilicate, Potassium. Continuous ECG monitoring until stabilized. The nurse explains to the patient's wife, his potassium is very high, which can stop the heart if untreated. We're protecting his heart right now, and dialysis will clear the extra potassium. Hypocalcemia, low calcium. Scene 1. Paramedics arrive. A 44-year-old woman collapses at a family BBQ. Paramedics find her anxious, breathing rapidly, hands cramped in a stiff position. Family reports she's had tingling in her face and fingers for days. She had thyroid surgery last week. Visual/physical signs: carpopetal spasm, hands flexed, wrists bent. Positive Chvostek's sign, facial twitch when tapped. Tingling around mouth and fingers. Breathing fast. Hyperventilating. Vital signs: HR 110, BP 100/60, RR 32, tachypnea. Scene 2. En route. Her muscle spasms worsen. She's unable to unclench her hands. Paramedics give oxygen and start IV access. They note she may be in tetany from low calcium, aggravated by hyperventilation. Scene 3. Handover to emergency team. Female, 44, post-thyroidectomy last week, collapsed with tetany and tingling, hyperventilating, carpopetal spasm, tachycardic. Likely hypocalcemia. Labs confirm calcium 2 plus 1.6 millimoles per liter, low ionized calcium. Mechanism explained. Clinician teaching moment. The ED physician explains. Calcium stabilizes nerve and muscle membranes by controlling sodium channel activation. Low calcium, sodium channels open more easily, increased neuromuscular excitability, tetany, spasms, seizures. In this patient, thyroidectomy may have damaged or removed parathyroid glands. Low PTH, low calcium. Her hyperventilation caused respiratory alkalosis, which increased calcium binding to albumin, leaving even less ionized calcium, worsening her symptoms. Scene 4. Treatment plan. Immediate intravenous calcium gluconate to relieve tetany. Continuous ECG monitoring. Oral calcium and vitamin D supplementation long-term. Endocrinology referral to assess parathyroid function. The ED nurse reassures the family her cramps and spasms are from low calcium, worsened by breathing too fast. The fourth calcium works quickly. She should feel her hands relax soon. Hypercalcemia, high calcium. Scene 1. Paramedics arrive. A 71-year-old woman is found lethargic at home. Family reports she's been slowing down, drinking large amounts of water, and more confused over the past week. She has a history of metastatic breast cancer and hypertension. Paramedics find her drowsy but arousable, lying on the couch. She complains of abdominal pain and constipation. When moved, she moans in discomfort. Visual/physical signs: dry mucous membranes and sunken eyes. Muscle weakness, can barely lift arms. Confusion, slurred speech. Vitals: HR90, BP 100/65, SPO 295%, RR 18. Scene 2, en route. Her mental status fluctuates. She drifts in and out of sleep. Paramedics note decreased deep tendon reflexes. They establish intravenous access and start isotonic saline. Scene 3, handover to emergency team. Elderly female, history of metastatic breast cancer, progressive weakness, abdominal pain, constipation, polyuria, confusion. Found drowsy, mildly hypotensive, dehydrated. We suspect hypercalcemia. Labs return. Calcium 2 plus 3.6 millimoles per liter, severely high. Mechanism explained. Clinician teaching moment. The ED physician explains. Calcium stabilizes membranes. Too much calcium reduces excitability. This causes muscle weakness, depressed reflexes, ileus, constipation, and lethargy. High calcium also impairs kidney concentrating ability, polyuria, and dehydration, worsening hypercalcemia. In malignancy, tumors can secrete PTH-related peptide, PTHrP, mimicking parathyroid hormone. Acid-base status can play a role. Alkalosis increases calcium binding to albumin, but in severe hypercalcemia, the total burden overwhelms this. Scene 4, treatment plan. Aggressive 4 isotonic saline for volume expansion, first line. Consider loop diuretics after rehydration to promote calcium excretion. IV bisphosphonates, e.g. zoledronic acid, to inhibit bone resorption. Calcitonin for temporary calcium lowering. Dialysis if refractory or if renal function severely impaired. The physician explains gently to the family. Her calcium is very high, likely from her cancer. We're giving fluids to flush it out and medications to bring it down. This is serious, but treatable if we act quickly. Hypomagnesemia, low magnesium. Scene 1. Paramedics arrive. The call comes from a shelter. A 52-year-old man with a history of alcohol use disorder has been vomiting for days, is now confused, and had a seizure. Staff report he hasn't been eating well and mostly drinks beer. Paramedics find him postictal, restless, and twitching. He struggles to answer questions, hands shaking. Visual/physical signs: fine tremors, eyelid twitching, muscle cramps in his calves, confusion and agitation. Vital signs: HR 118, BP 140/90, RR 24. Scene 2, en route. He becomes increasingly agitated, then has another tonic-clonic seizure. Paramedics manage airway, give oxygen, and establish IV access. They suspect electrolyte disturbance related to malnutrition/alcohol use. Scene 3, handover to emergency team. Middle-aged male, alcohol dependence, poor nutrition, vomiting, seizures X2, tremors, agitation. Likely hypomagnesemia. Vitals: tachycardic, hypertensive. Labs confirm. Magnesium 2 plus 0.3 millimoles per liter. Very low. Mechanism explained. Clinician teaching moment. The ED physician explains. Magnesium is critical for neuromuscular stability and as a cofactor for many enzymes. Low magnesium, increased acetylcholine release and neuronal hyperexcitability, tremors, seizures. It also impairs parathyroid hormone release, leading to secondary hypocalcemia, worsening tetany. In the heart, low magnesium 2 plus predisposes to torsades de pointes and other arrhythmias. Alcoholism and vomiting, low intake and high losses. Blood gases show mild respiratory alkalosis from hyperventilation, which further increases neuromuscular irritability. Scene 4, treatment plan. Immediate intravenous magnesium sulfate bolus, followed by continuous infusion. Cardiac monitoring for torsades and arrhythmias. Replace potassium if low, since magnesium 2 plus deficiency prevents potassium plus reabsorption. Address alcohol withdrawal with supportive care and thiamine. The ED nurse reassures the staff. His seizures were triggered by dangerously low magnesium. We've started IV magnesium. It usually works quickly to calm the tremors and stabilize his heart. Hypermagnesemia, high magnesium. Scene 1. Paramedics arrive. A 76-year-old woman with chronic kidney disease is found at home after her daughter noticed she was unusually drowsy and weak. The daughter says her mother has been taking a lot of milk of magnesia for constipation. Paramedics find her lying in bed, barely responsive. Her breathing is slow and her skin feels flushed and warm. Visual/physical signs: drowsiness, slurred responses, flushed skin, depressed deep tendon reflexes, barely present, weak muscle tone, shallow breathing. Vitals: HR 48, bradycardic, BP 80/50, RR 10. Scene 2. En route. She becomes less responsive, almost comatose. The monitor shows widened QRS and prolonged PR interval. Paramedics assist her ventilation and call in severe bradycardia, likely electrolyte disturbance. Known CKD, history of laxative use. Scene 3. Handover to emergency team. Elderly female, CKD, heavy magnesium laxative use. Drowsy, hypotensive, bradycardic, depressed reflexes. Monitor shows widened QRS. Suspect hypermagnesemia. Labs confirm magnesium 2 plus 2.8 millimoles per liter, high. Mechanism explained. Clinician teaching moment. The ED physician explains. Magnesium normally dampens neuromuscular excitability. Too much magnesium. Reduced acetylcholine release at neuromuscular junctions. Weakness, hyporeflexia, respiratory depression. In the heart, high magnesium 2 plus slows conduction. Bradycardia, AV block, widened QRS, risk of cardiac arrest. Her kidneys can't excrete magnesium effectively, and excess intake tipped her into toxicity. pH note: acidosis can worsen the cardiac depressant effects of hypermagnesemia. Scene 4. Treatment plan. Immediate intravenous calcium gluconate to stabilize cardiac conduction. 4 fluids and loop diuretics to enhance magnesium excretion, if kidney function allows. Hemodialysis if severe or if renal failure prevents clearance. Continuous cardiac and respiratory monitoring, airway support if needed. The physician explains to her daughter, her magnesium built up because her kidneys can't clear it well. We're protecting her heart with calcium and working to remove the excess magnesium from her system. Hypochloremia, low chloride. Scene 1. Paramedics arrive. The call comes from a nursing home. A 79-year-old man with a history of heart failure has been vomiting persistently for several days. Staff report he's been more confused and weak. Paramedics find him sitting in bed, pale and frail. He appears restless, clutching his abdomen. Visual/physical signs: dry mouth and cracked lips, slow, shallow respirations, tremors and muscle cramps. Vital signs: HR 110, BP 90/55, SPO 295%, RR 10, notably slow. Staff mention he takes a loop diuretic and has had poor oral intake. Scene 2. En route. His breathing pattern becomes slower and irregular. Paramedics note his mental status is deteriorating. He's less responsive. They suspect electrolyte imbalance with metabolic alkalosis. Scene 3. Handover to emergency team. Elderly male, history of CHF, on loop diuretics, vomiting for days. Weak, tremors, slow breathing. BP 90/55, HR 110. Likely hypochloremic metabolic alkalosis. Labs confirm. Cl negative 85 millimoles per liter, low. Metabolic alkalosis on ABG. Mechanism explained. Clinician teaching moment. The ED physician explains. Chloride is a major extracellular anion that pairs with sodium and helps maintain acid-base balance. Vomiting leads to loss of hydrochloric acid, HCl. Low chloride equals less available to reabsorb sodium with chloride in the kidney arrow. Kidney reabsorbs sodium with bicarbonate, instead aerometabolic alkalosis. This alkalosis depresses respiratory drive. Hypoventilation. Low chloride also contributes to muscle cramps and weakness. Scene 4, Treatment Plan. IV normal saline 0.9% NaCl to replace chloride and correct alkalosis. Potassium chloride supplementation if also hypokalemic. Monitor ABG and electrolytes closely. Address vomiting with antiemetics and GI workup. The ED nurse tells the nursing home staff his low chloride from vomiting is making his blood too alkaline, which is why his breathing slowed. 4 saline will help restore balance. Hyperchloremia, high chloride. Scene 1. Paramedics arrive. A 62-year-old man is brought in from a rehabilitation facility after sudden worsening confusion and rapid breathing. Staff report he has chronic kidney disease and recently had aggressive intravenous fluid replacement for dehydration. Paramedics find him sitting forward, breathing fast and deep, Kussmaul-like. He looks confused and restless. Visual/physical signs: flushed skin, dry mucous membranes, confusion, slowed responses, deep rapid breathing pattern. Vital signs: HR 102, BP 105/70, RR 28, SPO 297%. Scene 2, En route. He remains tachypneic, appearing to air hunger breathe. Monitor shows sinus tachycardia. Paramedics suspect a metabolic disturbance and alert ED, patient with CKD, recent IV fluids, worsening confusion, and Kussmaul breathing. Scene 3. Handover to emergency team. Male, 62, CKD, received large volumes of normal saline at rehab. Now confused, tachypnic, flushed. Labs pending. Initial labs: Cl negative 115 millimoles per liter, high, with normal anion gap metabolic acidosis, hyperchloremic acidosis. Mechanism explained, clinician teaching moment. The ED physician explains. Chloride maintains electroneutrality with sodium and balances bicarbonate. Too much chloride, often from large volumes of 0.9% NS. Kidneys excrete bicarbonate to compensate. Metabolic acidosis. This is why the patient is hyperventilating, to blow off CO2 and buffer the acidosis. CKD worsens the problem because kidneys can't clear chloride efficiently. Scene 4, Treatment Plan. Stop further normal saline. Switch to balanced crystalloids, like Ringer's lactate or Plasmolite, to avoid worsening acidosis. Correct underlying volume status and monitor electrolytes closely. Supportive management of metabolic acidosis. Bicarbonate therapy if severe. Dialysis if refractory or if renal function is significantly impaired. The ED nurse explains to the rehab staff his chloride is high from the fluids he received. That threw off his acid-base balance, so now he's breathing fast to compensate. We're switching fluids and monitoring his blood gases. Hypophosphatemia, low phosphate. Scene 1. Paramedics arrive. A 39-year-old man is found collapsed at home. His roommate reports he has HIV, poor nutrition, and recently started tube feeding after a hospitalization for pneumonia. Over the past day, he's been weaker and more short of breath. Paramedics find him alert but exhausted, struggling to breathe. He says his legs feel like jelly. Visual/physical signs: profound muscle weakness, can't stand unassisted, rapid shallow breathing, confusion, difficulty concentrating. Vital signs: HR 124, BP 95/60, RR 32, SPO 292%. Scene 2. En route. His breathing worsens. Paramedics note shallow tidal volumes. They support him with high-flow oxygen and prepare for possible assisted ventilation. They report severe muscle weakness, possible electrolyte or metabolic issue. Scene 3. Handover to emergency team. Male, 39, HIV+, malnourished, recently started tube feeds. Progressive weakness, confusion, shallow breathing. Vitals: tachycardic, hypotensive, tachypneic. Suspect severe electrolyte imbalance. Labs return. Phosphate 0.3 millimoles per liter, very low. Mechanism explained. Clinician teaching moment. The ED physician explains. Phosphate is essential for ATP production and 2,3-BPG in red blood cells. Low phosphate equals low ATP aero muscle weakness, including respiratory muscles, aero hypoventilation, respiratory failure. Low 2.3 BPG. Hemoglobin holds onto oxygen more tightly. Tissue hypoxia despite normal O2 saturation. His malnutrition plus refeeding, tube feeds high in carbs, caused insulin surge. Phosphate shifted into cells, refeeding syndrome. ABG shows respiratory acidosis from hypoventilation. Scene 4. Treatment plan. IV phosphate replacement. Careful monitoring for calcium phosphate precipitation. Support ventilation as needed. Monitor electrolytes closely. K+ and Mg. 2+ can shift with phosphate repletion. Adjust tube feeding regimen to prevent recurrence. The nurse explains to the roommate, his phosphate dropped dangerously low when his body started processing the tube feeds. Without phosphate, muscles, even breathing muscles, don't work properly. We're replacing it and supporting his breathing until it improves. Hyperphosphatemia, high phosphate. Scene 1. Paramedics arrive. A 55-year-old man with end-stage renal disease misses 2 dialysis sessions. His wife reports he's become increasingly weak, complaining of tingling around his mouth and muscle cramps. Today, he developed twitching and briefly lost consciousness. Paramedics find him alert but anxious, hands trembling and cramped into a claw-like position. Visual/physical signs. Carpopetal spasm, hands flexed. Facial twitching, muscle cramps and paresthesias. Vital signs: HR 105, BP 150/90, RR 24. Scene 2. En route. He develops worsening spasms and nearly seizes. Paramedics provide oxygen, secure IV access, and notify ESRD patient. Missed dialysis, tetany-like symptoms, possible hyperphosphatemia with hypocalcemia. Scene 3. Handover to emergency team. Male, 55, ESRD, missed dialysis. Weakness, cramps, paresthesias, carpopetal spasm, tachycardic, hypertensive, possible phosphate calcium disturbance. Labs confirm phosphate 2.8 millimoles per liter, high. Calcium 1.7 millimoles per liter, low. Mechanism explained. Clinician teaching moment. The ED physician explains. Phosphate is normally excreted by the kidneys. In renal failure, phosphate accumulates. High phosphate binds calcium, precipitates calcium phosphate complexes in tissues. This lowers serum ionized calcium. Tetany, seizures, paresthesias. Chronic state causes vascular and soft tissue calcifications. ABG shows mild metabolic acidosis, common in ESRD, which worsens calcium phosphate imbalance. Scene 4. Treatment plan. Calcium gluconate IV for acute neuromuscular symptoms. Phosphate binders, e.g. sevelamer, to reduce absorption. Hemodialysis to remove excess phosphate. Correct acidosis with dialysis/bicarbonate if severe. Long-term management. Strict phosphate dietary control. Dialysis adherence. The ED nurse reassures the wife. His phosphate is very high, which dragged down his calcium and caused the spasms. Dialysis will clear this and restore the balance, and restore the balance, and restore the balance.